Good morning, everyone. Special thank you to everyone here at the University of Scranton for hosting us. My name is Kyle Mullins. I'm a state representative from the 112th District here in Lackawanna-County. Very much appreciate all of the members of the public, individuals from the University of Scranton, as well as teams from Harrisburg for making the trip, as well as to my friends and colleagues up here in the hot seats. I am happy to stand in for Chairman Bizzarro, who is our chair of the Policy Committee for the House Democrats. So I will just take care of a little bit of housekeeping. Before we go any further, I would like to ask everyone, including myself, to silence our cell phones. And I would like all of my colleagues to introduce themselves. And we'll start, I guess we'll go, we got to pick one way. We'll go.
Pass this.
That's the right way to do it.
Good morning, Bridget Kosierowski from right here in the 114th Scranton and the Abingtons.
Representative Melissa Serrato, Montgomery County, House District 151.
Good morning, Jim Prokopiak, 140th District, Bucks County.
Good morning, Lisa Borowski, Delaware County, House District 168.
Good morning, everyone. Representative Eddie Day Pashinsky, 121st District, Luzerne County.
Thank you. Kyle Donahue, State Representative for the 113th District. I have the City of Scranton and North Pocono, and I just want to welcome my colleagues to the 113th District.
Paul Friel, Chester County, the 26th District.
Jim Haddock, the 118th District, serving parts of Luzerne County and Lackawanna County. Welcome, everybody.
All right, with that, Representative Kosierowski,
Thank you.
the hearing is yours.
All right, so good morning, and thanks for everybody for being here with us this morning. It is no surprise that we have an environment here of healthcare emergency, and certainly that includes access to care. You know, far too many Pennsylvanians, especially those in rural communities, that promise that they will have access to care. Their primary providers are miles and miles away. And wait times are not something that most people in an emergency situation have the luxury of dealing with. This challenge is especially urgent when we look at maternal health deserts and uncompensated emergency room care from the federal cuts that I worry people will have to absorb. Too many women are forced to travel long distance for prenatal and obstetric services, putting both mothers and babies at risk. At the same time, emergency rooms are increasingly the provider's last resort, delivering life-saving care regardless of patients' ability to pay. Today, we're joined by Dr. Pat Conboy, a longtime friend of mine. Dr. Conboy and I have spoken daily, maybe sometimes, about the environment here we face, certainly here in Lackawanna County. We had a hospital threatened of closure. We are fortunate to have been purchased by Tenor Health. Still with that, the challenge starts now on how to be able to make them healthy, to be able to have them survive, and to be able to make sure we have access to care. So thank you for being here with us today. We're looking forward to your testimony and the questions that will come from the members here today. Thanks, Dr. Conboy.
Good morning. First of all, thank you. There's not a shot clock here that was going to make me like, seeing the numbers tick down was really going to throw me off. Dr. Pat Conboy, for those who don't know me, I am a family physician by training. I spent 10 years in military service, and what I, to this day, always point out is the greatest socialized medical system on the face of the earth, the United States Army Medical Corps, and maybe those other services too help a bit. After a decade in the Army, I came back to Scranton. I had a private practice here for 27 years. And just short of a decade ago, I moved into hospital administration. I have been the chief medical officer for the vast majority of that time for Moses Taylor and Regional Hospital of Scranton. And while I still maintain that position, I've recently added to my title the VP of Clinical Services and Quality for Tenor Healthcare. So I've had a really good chance to experience the changes in the healthcare system and the struggles, most importantly, that the average patient goes through. I like to talk about the hospital for a moment, but when you look at access, it's essentially a door. For 1 second, the other side of the door, the patient problem's just getting to the door. And I appreciate that you've already mentioned this. Over the last number of years, we've seen that commercial insurance prices have gone through the roof. And while I applaud what Obamacare attempted to do, those couple little lines that allowed deductibles and co-pays to go through the roof have become a massive barrier to people getting the care they need. And now as we see cuts in Medicaid, more and more people are going without insurance, without care. And then the few people who actually have insurance and can go see a doctor, because of the declining number of physicians in the area, have a hard time getting in. And when they get in that door and the doctor says you need a studies, well, now they need a prior auth and a whole circus starts, and sometimes they get it and sometimes they don't. And if they get through that door and the doctor prescribes a medicine, now I've got a pharmacy benefit manager who's also standing between that patient getting the care. And the end result is a massive number of people in our community aren't getting what they need. And they all end up knocking on the door of the hospital, whether it's psychiatric patients or patients with somatic problems. They all end up in the same place. The couple emergency rooms that we have. Right now we have 2. A week ago we had 3. Recently, the second largest one in the area, our emergency room at Regional Hospital Scranton, would have closed had Tenor Health not stepped in to keep us open. There was no question about that. Community health systems had already published their plan to close that hospital. And quite frankly, Wilkes-Barre General Hospital in Luzerne-County would have followed within a few years. There's just no doubt. They're leaving these communities with a single emergency room that, by the way, is already overcrowded, as is ours. But you get to that door and you walk in, and guess what? The hospitals aren't able to give you the care that they'd like to do either, due to decreased number of doctors, nurses, staff, and cut services. Why has that happened? It's happened for a simple reason. They can't afford it anymore. What we have seen over time is that hospital payments have not kept up on purpose with the cost of living and the cost of providing that care in this community. Our staff, our nurses, our doctors, our technicians, the people who clean those rooms, they deserve to make a living wage. But with the reimbursement we're getting, we can't do that. Recently, and I applaud it, there has been an attempt to help level the scale between the rural areas and cities by starting to put money into rural health care. But what people didn't see was that just exacerbated the problem in medium and small size cities, because now, yes, a rural hospital can give a competitive salary with New York City, but I can't. And so we've seen further outmigration of nurses and doctors, et cetera. And before that, for the last decade, we fought this wage price index. That was a 1950s concept that had the idea that an employee at a hospital lived in that city. And so Philadelphia or New York City, they paid their people more. But guess what? You know where those people who live? Here. They live in Scranton. They live in the Poconos. They don't live in that city. So why would they work here for half the money they can get at the end of a 1 hour or 45-minute drive for many of them? So we can't compete with that. Our prices don't cover our costs. Our reimbursement doesn't cover the costs. And by the way, we didn't cut reimbursements to the people who sell the equipment. That CAT scanner still costs a fortune. The drugs still cost a fortune. And so when somebody says, well, you come into my hospital with a stroke and I'm going to give you $100, maybe that made sense 5 years ago. But now the first medication I give you takes up about 20% of the entire cost that payment for the DRG has for my hospital. It just doesn't work anymore. And all of this has been exacerbated by the movement of managed care into Medicare, Medicaid, let alone commercial insurance. When you set up a system that essentially rewards somebody for not delivering care, the less care you give, the more money you make. All this talk about quality metrics and all those things aside. The reality is managed care in Medicare and Medicaid makes money by not giving care to the people who you take care of and I take care of every day. That march has been very difficult on all of our hospitals. What we see is they deny care. Patient's been in the hospital for 2 weeks. With a swipe of a pen, we're not paying you. We don't think that patient should have been there for 2 weeks. We don't think that patient should have had this surgery. Again, a nameless person at a distant number has decided that that care should be for free. That adds on to the pile of people, as we've already said, who have lost their insurance, who don't have enough money, and they knock at our door, and there are laws that say, and ethical considerations, I have to take care of them. So more and more care goes unreimbursed. The reimbursement goes down for everything we're getting, and the cost goes up. And so now we have Moses Taylor Regional Hospital, Wilkes-Barre General, all hospitals who have had small margins or negative margins. And they've struggled for a decade, and it's getting worse. I am very thankful Tenor Health stepped in to help us. But quite frankly, Tenor Health can't fix the broken system. They're not going to make it when Moses Taylor failed, and Catholic Health Partners failed, and CHS failed, and all these other, because the system is set up against them. We really need the state and the government to step in to help us. There are a couple things you can do. One, I think looking at how we distribute some of this money that's going to come into the state is going to be extremely important. Don't forget the medium and small size cities, because as I told Dr. Oz when he came through, you have to be careful if you're going to flood a desert that you don't drain an ocean. And that's what's happening at the moment. Stop the march of managed Medicare and Medicaid coming into our system. Work on these companies and their denials and the constant paperwork they have. We have more people working paperwork than working patients, and that's no good for anybody. And finally, if you want to help the patients out on the street too, if we could do something about PBMs, that would really help the average guy in the street. That's my tirade. Thank you.
Thank you. You heard a collective moan up here when you said PBMs. I don't know if you could hear that.
9 votes for you.
Yeah, we understand, believe me. You know, the landscape is bleak to listening, but it's about our patients and it's about healthcare, and we have a duty to fix it. And again, like you said, Dr. Conaboy, the Tenor Health, we are certainly grateful for them being here. What you're talking about is universal across the whole entire country. I want to keep it Scranton-based today because of this is what we're talking about. And by osmosis, my colleagues up here, Mullins and Donahue and Jimmy Haddock here in the Northeast, and Eddie Day Perchinsky, we got trained up on healthcare administration, medical reimbursement. We kind of all kind of had to quickly learn about it. I didn't have to learn so much because I'm a nurse. I don't know if anybody knows that, but I'm a nurse. So I already knew all this, but I was patient with my colleagues to let them learn. So
That in the paper.
Yes, thank you. Yes, but anyway, I do have to say the challenges that we have now are so great that when you talk about Moses Taylor Hospital and Regional, where you are where you reign, right? Geisinger, and we all know that emergency room is constantly overjammed with patients. And you did speak about the different types of patients that come through those doors. I've always said the worst place for a patient in an acute psychiatric crisis is to be in an emergency room. That is the worst place for them to be. We have to do better with that patient population. But how do we do this when we are constantly asked to cut back, And I don't blame the nurses and the physicians and the support staff for leaving and going elsewhere because they're getting paid more an hour. I don't blame them from doing that. I'd like to keep them local here in our hospital system. But at the end, you kind of talked about a little bit about what is the biggest challenge right now to keep those doors open? We kept them open. We had a fire last week, right, in our emergency room, Lehigh Valley. Not great for this setting. Hopefully they'll open soon enough. But what is the biggest for Tenor Health to come here? Is it recruitment? Is it new doctors to come and make revenue? Is it the federal? Because I know it's a parallel issue, the reimbursement rates, and that's a federal issue. And we don't have partners in the federal administration right now that understand and are doing the right thing. So that's an added challenge. Where do you see Tenor's biggest barrier for success right now to keep our hospital happy, thriving, and accessible for our patients? We do have the only NICU, right? Level 2, the level 2 NICU. That was our real crisis mode, and that's why I think that there was some right from the governor's office to say we got to keep this place open. So where would you say the biggest challenge for Tenor right now? What do we got to do in us to be supportive up here to keep the doors open?
The biggest challenge for the hospitals right now is the term you use, recruitment. Yeah. And understand that's not just recruitment of physicians, which is a huge problem for us, but it's a recruitment for every position in the hospital, top to bottom. That's a challenge for a number of reasons. One, as I've already alluded to, the cost of bringing on an employee has become very difficult for any hospital to manage. Even if I want somebody without advanced training who's coming in to do environmental services, et cetera, we are competing with Chewy, who will pay you $20 an hour to drop a dog bone in a box. And so there's that pressure on us of when you get to the higher things, whether it is nurses or critical care nurses or physicians or specialists, we have to be able to assure them of two things. One, that we can pay them a competitive salary, and two, that we'll still be here in 2 years. For me to ask somebody to come and work for me is not just a matter of salary. They're investing in me also. If I ask a doctor, a specialist to come and work in my hospital, most likely a family is moving with them. They have to invest in this area. I can sell this area like there's no tomorrow, but the tenuous future of the hospital due to all of these financial pressures purely is our biggest challenge. And the same with nurses. Quite frankly, nurses move all around the state now, and they move to other states if they see progression. But they're not going to come here. They're not going to take this job until they feel that we are financially stable and have a clear future. And that has to do with rebuilding the entire infrastructure. And that takes money. I'm sorry, at the end of the day, it's money.
Thank you, Dr. Conaway, for being here today, and thank you for your advocacy, because I think we all know that, as private equity sort of ravaged healthcare, especially in this area, it was the local people, yourself included, that kept the operations down the street going and serving our community. So I want to thank you for that. I want to thank your local staff for that as well. But given that, and with a new owner coming in, I think some of the issues we saw throughout the process over the last couple of years was decisions were being made by CHS in Tennessee that were directly impacting us here, but it was the local people keeping it going. So how could we help you in terms of keeping local people involved in leadership decisions and making sure that we're doing what's best for the community and not only the bottom line?
One, I think making sure that the conversation continues between the state and the hospital is really important. If the question is how do we continue to keep our local people involved, and again, let me just be clear, everybody at these hospitals in Scranton can get a better job someplace else. Every single one of them. And every one of them can take that job and be sure that their paycheck is going to continue for the next decade. but so many of them have stayed. If you walk through my hospital, 30 years, 40 years. I'm one of the new guys still with just a little over 30 years in the hospital. There are literally people who just recently retired who were in the OB suite when I was born at that hospital, by the way. But keeping those people involved, being able to get them to move forward, I have to say Tenor has been very aggressive about saying that they want the people who have been running the hospitals to continue to help run the hospitals. One of the pluses and the minuses about Tenor is that they didn't come in like some other organizations might have with an out-of-town group of people who they were going to helicopter in to run the place. We do have to make sure that the local voice continues to be loud and heard. We have the advantage that, as I told our employees, on February 1st, over 90% of Tenor became Scranton and Wilkes-Barre. We are the Tenor organization. And I think anything that we can do for the Tenor organization benefits this area because, as I said, we are 90% of the organization.
Thank you. And, I've been saying for the last couple of years too, right, that the thing that keeps those hospitals running is the local people, and we're more than willing to help in any way we can.
I appreciate that.
Going.
I've always said, I don't care what the name is on the walls. It's the people between the walls that matter.
Absolutely. Thank you.
I want to thank you for that optimistic overview of healthcare. I'm up here today because I'm in a similar situation down in Chester County. We've seen, the closure of Crozier and Brandywine, and I live in an area with two hospitals that are owned by Tower Health that has been struggling to keep them up. Recently, they just laid off 200 and some people from Pottstown Hospital, which we've closed the ICU and the emergency room. We've closed the cancer center. We closed maternity a couple of years ago. I'm not sure what's left to call it a hospital, right? And here's the thing: when private equity-backed companies own assets and they treat them as assets that they can monetize, there's no equation that says community health outcomes matter. And I'll give you, for instance, as we see decisions made to send assets to this hospital or this one, or the reimbursement rates, when you see unreimbursed emergency room visits, or my percentage of Medicare payments are, I say, oh, I'm going to move these assets to better performing where I have more private pay and I have a better mix. So what happens? The most vulnerable communities in our state are left with the least ability to absorb the move, now have to drive for healthcare further, and they're much less likely to be able to do that. It's not communities of wealth that have this, and so our most vulnerable populations get the least healthcare. And but I have a question for you, because between managed care on the pharmacy side, between the reimbursement rates, between the geographic differentiation. I'll give you another example, 340Bs. So this hospital doesn't, and the cancer center doesn't qualify because it's regional and just misses a percentage or two. They do $9 million in cancer infusions. It costs them about $11 million. If they were a 340B eligible, they'd be paying about $6.5 million instead of $11 million. That's the difference between having a hospital be able to make money or survive or not, just based on somebody checked a little box and said, here's where we are. But another hospital that can come to that same community, set up that same system that has the 340B and be able to do it profitably. It just makes no sense. When you look, and you mentioned the geography differences and the indexes and pay and stuff like that, if you were to pick the number one, two thing that we could do as state representatives here in Pennsylvania to change something about reimbursement or something about how hospitals are paid, what's the biggest impediment that we could kind of remove so that there's more equitable distribution of money towards our rural hospitals and towards our communities that are vulnerable?
It's a big question, because again, the payment system to hospitals is so complex between state government, federal government, commercial insurers, the insurers who own hospitals and make their own rules for the folks inside and different rules for the folks outside, and I don't need to name those people, and who, when you look at it and someone says, I'm not for profit, but I have $3 billion in the bank and I'm laying off people and raising prices, I'm not sure how that fits that definition, that it's any different than the private equity groups doing the same thing. But if I were to change one thing, I would pay, if I had my wand, every hospital would be paid the same. Mm-hmm. That if I got care at Wayne Memorial or at Jefferson in Philadelphia, that I'd be paid the same price. And that would help level the playing field so that every hospital can attempt to hire the people they need, get the equipment they need, and also give out the medications that they need to do. And to your, two good examples of what you're talking about on the way out the door, CHS sold the labs out from underneath Wilkes-Barre General Hospital. That will cost that hospital close to $10 million a year that they took on the way out the door, they took out of the pocket of that hospital. On the 340B thing, we find that Scranton Regional Hospital in Moses Taylor will qualify as a 340B, but 20 miles away, serving almost the exact same community, Wilkes-Barre General will not. And forces us to try to juggle that concept, and how that's going to impact the people who come looking for care is something we're still trying to figure out to keep it equitable, but not make the obvious business decision.
Yeah. Thank you very much for that.
Along the same lines of Dr. Conboy and to Representative Friel's comments and yours, we keep hearing rural health, got to get reimbursements for rural health. And when I have the conversation with people, that drive of rural health seems to confuse people, because if you're a city, people assume every city is a city. And you in your testimony, and I thank you for that, talked about medium-sized cities, because I don't think out in public, and this is where the pressure has to come from besides ourselves as legislature, the public has to understand that it's not just the city reimbursement and rural reimbursement. You just said it. Every reimbursement is very important and should be put on a level playing field. Everybody should be paid the same, was your goal, is your want. So can you briefly give us an overview of the reimbursement, the complex, and you did say it was a complex reimbursement schedule, but even people here in northeastern Pennsylvania, where Wilkes-Barre and Scranton predominantly houses our hospital and, of course, Plains systems, we don't realize out in public that there's a difference between Wilkes-Barre's reimbursement, Luzerne County's reimbursement, and Lackawanna-County's reimbursement, and the plight of the hospital system for the lower reimbursement and medium. Can you touch on kind of the different levels of reimbursement?
Let me touch on the wage price index concept to begin with. The wage price index is an odd concept that was designed years ago to help hospitals in big cities. But if you look at it as a given procedure, is like buying a candy bar or something. A given procedure, or that candy bar, let's say it has a value of $1. The wage price index says that if you're in Philadelphia, the government will give you $1.30 for that same candy bar. But if you are in Scranton or Carbondale, they'll only give you 85 cents for that same candy bar. And at one time, maybe that made sense, but now we're all getting the candy bar from the same manufacturer. And so how possibly can I sell that candy bar for 85 cents? And why is a guy in Philadelphia getting $1.25? That's essentially the easiest way to look at the wage price index. How we get paid in other areas becomes even more complex. As the number of insurers go down in an area, as we've seen has happened in Lackawanna and Luzerne-County, less people at the table, the insurer basically can come to the table and say, if you want our patients, we're going to pay you 90 cents for that candy bar. If you don't want to sell us a candy bar for 90 cents, fine. We'll take our 2 million patients someplace else. And by the way, we have our own candy factory, and we'd be just as happy to only sell our own candy bars anyhow. And that has happened more and more aggressively over time. So the government started the process of telling us our care was worth less than care someplace else, and the insurance companies then use that number to base their reimbursement to us, along with the fact that they can strong arm the smaller and independent hospitals, and so we get paid less there. So frequently, one of the things that people get upset about is that a hospital won't tell you how much a procedure costs or how much a doctor's visit costs. I can tell you, I ran a doctor's office for 27 years, and when people would ask me, how much do you get paid for a visit? I always had the same answer, I have no idea. Because insurance B gave me $20, insurance C gave me $65. I put $35 here, but then what I found out was because C is willing to pay me $65, but I have to charge $65. So now I have to say I'm going to charge $65. I know I'm still only going to get 20 over here. And there's a lot in between. So how am I supposed to know what I get paid? It's a game where the rules keep changing, and where, quite frankly, the person, if I was making bread, I would know how much it costs to make a loaf of bread, and I would put it out and say, buy my loaf of bread for $1.10. I'm making a loaf of bread, and everybody and their brother is telling me what they're willing to pay for it, and they don't ask my opinion. So it becomes extremely difficult.
Morning, Doc. Want to touch base a little. We've seen in the papers the last couple of days that due to the loss of the enhanced tax credits from the federal government, that Penny has noticed a 20% decrease in coverage for those who are going through the exchange, and higher numbers in rural and older Americans. Can you give Pennsylvanians? Can you give us what the impact is for your hospital, and also what you plan to do about it?
I'm sorry. I'm doing the best I can hearing with this thing. Could you repeat the question?
Sure.
Or if you mind, I'll just come up and stand closer to you so I can.
That's all right. So we've seen that Penny has seen a 20% decrease in insurance through the exchange because of the increased cost and the loss of the premium tax credits. And it's higher among rural and older Pennsylvanians, which is obviously a bigger part of this area. So what is the impact for your hospital, and what is your game plan to, I guess, alleviate some of those negative impacts?
So if I understand the question, we're talking about the fact that there have been cuts across, and how does that affect the hospital? You can imagine a hospital like Moses Taylor or Regional Hospital who have lived on the tightrope for years. One year I make $1, the next year I lose $1. One year I lose 19 million, the next year I don't lose quite as many. Those type of cuts result in only one thing: less nurses, less doctors, less services, less equipment being replaced that's outmoded or out of date, stricter rules on the formulary. In other words, decreased care, and more people looking for it. Again, we can't do what some people can do with loaves and fishes. And we're close to the point where that's what the world is asking of us, is we're going to give you less and less and require more and more. And it almost put us out of business until 2 weeks ago. And if something doesn't change, we're not going to be able to remain in business. And this community will have one full hospital left.
Well, thank you for all of your answers, Dr. Conaway, and for your testimony. I really appreciate it. And it's really refreshing to hear from a hospital administrator who not only speaks so eloquently on the business end of it, but on the people end of it as well. And I can tell you bring your family practice physician heart with you to this job. So, and I just want to say to my NEPA colleagues, I certainly, feel your pain. So from Delaware County, and I know that Rep. Friel mentioned it earlier, I have a county of over 500,000 people. We are down to 2 hospitals. We lost Crozier Health System because of private equity, and anyone who's interested in helping with private equity, let's get House Bill 1460 passed. There's a little pitch for a private equity bill. But, so we saw firsthand, what the devastating impacts, and I'm glad to see that you're working with Tenor. We had talked with them around our Crozier situation. And hopefully we're going to see things get better because of that, but right now we are definitely struggling. But one of the things that I don't think we often talk about when we talk about our hospitals and our health systems, we talk about access to care and we talk about how important that is, and certainly it is, but what we don't talk about is how they're also the economic heartbeat of a lot of communities, and how losing those hospitals not only impacts the people that work there and the people who might seek care there, but the entire community. So can you talk to me a little bit about, just to educate me, and I know Bridget said we want to talk about Scranton here. Can you talk to me a little bit about what that looks like for you all and what your hospitals mean to the community beyond just providing health care, which certainly is the most important thing, but in Delco, we've seen it significantly impact in ways beyond just health care.
Yeah, we go way beyond healthcare. First of all, the simplest thing is we employ over 1,000 people just at Moses Taylor and Regional Hospital. If you include Wilkes-Barre General Hospital and that, we go over 2,000 people that we employ. In addition to that, we run training programs for every nursing school in the area. If Lackawanna College loses us, the University of Scranton, Marywood, Penn State, Jersey College, those are some of the groups that we are training. We work with the University of Scranton on training physical therapy and radiation techs, et cetera. So we are working every day on the future workforce as well as the current workforce. Of course, we work with the Wright Center on training residents and fellows. If our hospital were to close, the Wright Center would not survive. And the care that they give in this community would crumble quickly because there is not a place for those residents and fellows to go to be trained without us. We are their sponsoring institution across all of those programs. And it doesn't take a lot of imagination to realize if I'm a business looking at coming into your city and you have one hospital that has already been rated the most overcrowded hospital in the state of Pennsylvania, I'm going to take a pass. That pass might include that train that we all keep dreaming about, but we don't want to say too loud we don't want people to hear and cancel it. But the economic devastation that would happen if these hospitals closed in Scranton and the one in Wilkes-Barre, far beyond the tax income that it's dwarfed compared to the tax income that the for-profit organization may or may not have been paying. That's a discussion for another day. But yeah, I don't think that the city of Scranton could survive with only Geisinger CMC. And that has nothing to do with the quality or anything else. It's purely a numbers game.
Thank you very much, Doctor, for your wisdom, your knowledge, all that you do. Unfortunately, unless we do something about it, it's not going to get any better, will it? What do I mean? I'm strongly recommending, if you have other colleagues like yourself that is this knowledgeable, to actually come up with and lay down a plan. And I'm saying that to you because it's not going to get better. It doesn't appear that it's going to get better. We as legislators can't provide a particular regulation or a law until we have the right information before us. Healthcare is life and death, but it's now become profit. If you don't have insurance, well, that's tough. So many years ago, when I started, we put together a group, and one of the possible solutions was everybody pays in, just like you do Social Security. Everybody's guaranteed health care. Everybody's paying into it. And then everybody should be able to regulate a reasonable, profitable amount of money so that everyone can conduct their business, whether it's insurance person, whether it's the head of the hospital, whether it's the guy driving the ambulance. Everybody should be paid appropriately. I don't have those numbers. This is extremely complex. And the question that I'm going to give you, number one, would you be willing to gather some other qualified individuals like yourself that know the system so that we could take it and rip it apart? How much does that insurance raise the prices, for that emergency room? How much do we have to fund through a federal program, through a state program, through a tax dollar in order to make sure that people that need health care get it? And they're going to get quality health care. It's unimaginable that Wilkes-Barre and Scranton, you're talking about several 100,000 people, won't have a hospital, or it's just Geisinger and they can't handle it all? Wait a minute. This is America, for God's sake. All right, we got a problem. Let's sit down and discuss it and honestly rip it apart. What do we do for insurance? What do we do relative to the cost of a particular service that you're providing? And I know that my colleagues are very much interested, but when you talk about it in this way, it's difficult for us to try to come up with a law or regulation to try to solve a problem. It's too complex. So I'm asking, and I'll tell you something else to consider. Let's do a pilot program. Let's do a pilot program in Northeast with the new system that we put together and develop, okay? I just passed that on to you only because I'm willing to put the time into it. I may have a little more coming up. But I did, I put together a group, this goes back to 2007. And there were doctors, there were nurses, there were insurance people, there were lawyers, pharmacists. And the idea was, how do we fix this? What do you think we should do? Now, the folks that are in the audience may find this humorous. At that time, we were concerned about the cost of health care because the normal insurance cost was $5,000. What's that insurance cost now? $25,000 plus, okay? So my point is it's
I
not...
thought you were talking about a month.
There you go. Yeah, it's out of reach, it's out of control, and the fact is a lot of people don't have the health care they need. In Wilkes-Barre, for example, we have volunteers in medicine, Dr. Sodoni. Thank God for those things. Many of those people wouldn't have any of that stuff. So I think we just need your your intelligence, your knowledge, information, experience to help guide us to try to do the right kinds of things.
As I've told a number of folks on the panel, I'm absolutely willing to try to work on whatever solutions we can come up with, both short, medium, and long-term.
Okay.
Other states have started to dip their foot into that, some in a big way, some in a small way. Yeah, the solution is clearly not going to come straight from the federal government. When it's a hospital that has next to no money versus an insurance industry that has trillions.
Yeah.
Sometimes that little guy with the rock wins, but that's not who you bet on.
Yeah. But Doc, thank you very much. And if you want to write us a dissertation to let us know what you want to do, because one of the things I will always ask, if you had the power, what would you do? How would you start? And what's your plan? Thank you.
All right. Thank you so much, Doctor, and for the very thoughtful questions and answers by this panel and from you. Thank you. I'll just, because we're going over on time here, I'll just close your time up here with an observation. Well, first, a thank you for hanging in there. You've been through all of the uncertainty at that health system, as have the amazing people on that campus, and as well as the people up here have been with you. And we're glad that the story ends, that there's a happy ending to that.
The story's just begun.
This,
The next
so,
chapter.
right. So with that, thank you. I also, just an observation, I know we're months away now from Christmas time, but in our house, The Grinch is one of our favorite holiday movies. And as you were talking about CHS leaving town and stripping and taking the lab services with them, I couldn't help but think of, as he was cleaning out the house and taking the last can of Who Hash and a crumb too small for a mouse.
They didn't even say they were going to bring it to the workshop and bring it back later.
Right. But I think it speaks to my broader observation is I hope that we as a country, as a state, as an industry have learned our lesson from the failed, ill-fated experiment of for-profit, private equity healthcare. I've always said you could care about patients or you could care about profits. You can't care about both. And thankfully, this health system, and it was close on so many days to closure. I'm thankful this health system survived the experiment. But the only trial that should be happening in healthcare is in a lab with clinicians for better patient outcomes and cures to diseases. Not an experiment of bringing for-profit private equity intentions into the healthcare of people. I'm glad that this happy story continues and is just beginning, and I thank you for your continued service and for being here today.
Thank you. And I'll leave you with, there was a guy a lot brighter than me who commented on that. Basically said a man cannot serve two masters. And you can't serve two masters.
Amen.
Thank you.
Thank you, Doctor.
I say bring back the IHM nuns. When the Mercy Hospital was running, they were like fierce. So we'll bring back the nuns and we'll say that. They were the yeah. Right. Thank you, Doctor.
Thank you so much, Doctor. Our second panel, we are very grateful to be joined by Dr. Maria Montoro Edwards, the President and CEO of Maternal and Family Health Services, as well as Jill Avery Stoss, the President and CEO of the Institute. Thank you both so much for being here.
We didn't decide who was going to go first. Good morning. I'm Jill Avery Stoss. I'm president and CEO of the Institute. We are providers of data analytics and community-based research services, and we spend a deep time doing our work in the healthcare space. I'm going to kind of reiterate a lot of the points that we've already heard that I think are particularly valuable, and then add a few of my own as well. And I also want to start by acknowledging that we really do know that our region benefits from some incredible provider networks, and we have some great medical education programs. But those gaps to access are certainly really, really persistent, especially, as we know, in those rural areas in primary care, behavioral health, maternal health, and for affordable services for folks who are uninsured or underinsured. These gaps influence how easily people can not only get the care they need, but how effectively the system operates as a whole. So as Dr. Conaboy mentioned, the closure of hospitals and other facilities is among the more pressing issues that we're facing in terms of access. Community and rural hospitals in particular are operating with really, really limited margins. They're providing care to everyone who comes to them regardless of insurance status. And so when fewer people have that coverage, the hospitals really are reimbursed less and less. And over time, that is creating a financial strain that isn't sustainable for any institution. When the facilities close, those effects are immediate. We're seeing people who have to travel farther and farther for routine services such as prenatal care, cancer treatment, dialysis, even their primary care visits. Emergency care is also farther away, adding more logistical challenge to the conversation. And then that's where, as we've heard, that's where insurance coverage comes into the conversation. It's very much about individual affordability, but it's also such an integral part of how hospitals and clinics are sustaining themselves. The more we have people who are insured, the better reimbursed the systems are. And when that coverage declines, that pressure on the hospitals increases. But healthcare access has much more economic implications than that as well. We know that when people can access their primary care, their preventative services, whether they can access mental health care, they generally remain healthier. They're missing fewer days of work. They're staying employed more consistently. And then conversely, when that access is limited, there's a lot of chronic conditions that are going unmanaged, mental health needs that are escalating, and preventable issues that are getting a lot more serious. So then employers are seeing higher absenteeism and lower productivity, their own rising healthcare costs, and that effect is rippling throughout the economy. Delayed care also leads to higher costs. Without quick access to doctors, a lot of individuals end up in emergency departments where the treatment is significantly more expensive. We know that preventative care is much more cost-effective, and the financial benefits of that effectiveness accumulate over time. And beyond all of that, healthcare is a major economic sector in northeastern Pennsylvania. In 2025, the region's healthcare sector generated a gross regional product of $5.4 billion, and that's $4.6 billion in earnings, and then another $120 million in tax revenue. So hospitals, clinics, long-term care facilities are among our biggest employers in a lot of Pennsylvania communities, and then especially in those rural areas. So for example, for a region the size of Lackawanna and the surrounding counties, the national average is about 52,000 healthcare employees, but here we have more than 62,000. We are significantly beyond that national benchmark in terms of healthcare as a key economic sector. The demand for that care already exceeds the supply of people who are available to provide it. Then we have that workforce shortage. And so the loss of facilities means the loss of more jobs and more providers and then more economic impact. So the bottom line really is that the healthy populations do support the stronger economy as a whole. Folks who can access reliable care are better able, they do better in school, they do better at home, they are more secure in their housing, those social determinants of health are stronger, they stay employed, and they're really better able to contribute to their communities. When that access breaks down, the effects show up in lost productivity, higher public spending, and reduced economic competitiveness. So ensuring that access, whether through insurance coverage, strengthened systems, and a sustainable workforce is what we need for community resilience.
Good morning. I'm Dr. Maria Montoro Edwards. I'm President and CEO of Maternal and Family Health Services. And I am so happy that you are having this testimony today because we all know that maternal and child health outcomes are often the bellwether of a community's health and resilience. And so thank you for this opportunity today.
10:57 a.m.
Sorry about that. I don't know how that happened. MFHS has been a trusted provider of health care in northeastern Pennsylvania since about 1971. We serve more than 100,000 individuals in 17 counties through 28 locations and 2 mobile units, delivering maternal and child health services, nutrition, breastfeeding support, reproductive health care, and the Nurse Family Partnership Home Visiting Program. In fact, I think that we're in all of your districts except Field. We are not in Chester County. So, I'll have to look into that. MFHS is proud to be the largest WIC provider in Pennsylvania. We serve 27% of the entire Pennsylvania WIC population. That's about 50,000 mommies and babies every month. And I can tell you that WIC remains one of our nation's most cost-effective and cost-efficient public health programs offering nutrition, education, breastfeeding support, access to healthy foods, and key referral to health services in other parts of the community. Every day we see how WIC strengthens the families and gives them a good start. I serve on the Pennsylvania Maternity Mortality Review Committee for about the last 5 years, and I can count on one hand the times I've reviewed a maternal death where mom was also engaged with WIC. There are definitely protective factors there. One of the challenges, unfortunately, is WIC funding is not keeping up with expenses. And so currently we have several WIC positions frozen because the grant funding hasn't increased more than a couple $1,000s in the past 4 years or so. And so it's getting a little more challenging, and it's very hard to say to somebody that we can't accommodate them for an appointment for 3 or 4 weeks. And so we're doing the best we can with mobile units to get out into the rural areas, but we would be greatly appreciative of WIC funding increasing. A major innovation for maternal and family health services in our region is our Circle of Care maternity medical home in Lackawanna County. We have a wonderful partnership with Dr. Conboy's team, Moses Taylor Regional, and the Physician Health Alliance. Dr. Rabin is our medical director, and he's wonderful. So this is the first of its kind in Pennsylvania that I'm aware of. Since opening, the Circle of Care has provided tens of thousands of visits and supported more than 1,000 maternity clients through integrated prenatal care, ultrasounds, oral health, breastfeeding support, postpartum anxiety and depression care, maternity clothing, care navigation, nurse home visiting, and WIC, all in one location. What we're trying to do is remove the barriers that mom has. So she can get to our location, we can provide all the services in one area. We hope this will be a pilot program for other areas. We just opened another location in Monroe County, and we hope to see that we will be able to provide additional wraparound supports for moms in Monroe County. Our outcomes are very good. MFHS served 322 new maternity patients in 2025, and that was 257 deliveries. While 90% of these patients had at least one high-risk factor, our preterm and low birth weight rates were lower than county and state averages. Good maternity care is expensive. Reimbursements don't nearly cover the cost of providing this care, and were it not for the generous support of our regional philanthropies, our foundations, our individual donors, we could never provide this level of care. We're launching a new program in our rural WIC clinics. We found that 81% of our moms were looking for postpartum anxiety and depression counseling. 62% experienced times when they needed counseling and it wasn't available, and 78% said they would use telehealth for prenatal and postpartum counseling. These findings underscore the importance of accessible, flexible care models where they are. So we're rolling out these behavioral health supports in our rural WIC locations, referrals, treatment, and screenings. Beyond direct services, MFHS provides regional leadership with our partnership, the Institute, as the convener of the Northeast Regional Maternal Health Coalition. We have over 100 active participants across 14 counties, including payers, community organizations, academic partners, and individuals with lived experience. And together we're developing a comprehensive regional maternal health plan grounded in local data, community priorities, and the recommendations of the Pennsylvania MMRC. Our key items of focus are rural transportation, care, maternity care deserts, integrated care, and care coordination to make sure that there is somebody monitoring all of mom's care. We're not in competition with one another. We're in competition with maternal and child infant mortality, maternal mortality, and morbidity. MFSH programs demonstrate positive outcomes for families facing economic hardships, food insecurity, housing instability, transportation barriers, and other drivers of health disparities. Our Nurse Family Partnership Home Visiting Program pairs a new mom, first-time mom, or potentially a mom with 1 or 2 children through a child's second birthday, and this shows particularly strong results. 95% of babies are born full-term and over 5.5 pounds. Breastfeeding initiation rates are at 84%, and 92% of children are fully immunized by their second birthday. At the same time, unfortunately, the families we serve are facing increasing challenges. Affordable housing remains out of reach for many. Food and utility costs continue to rise. More clients than ever are answering yes to the question of, have you had to choose between paying bills and utilities and groceries? Transportation barriers persist, and many families rely on food banks and MFHS for basic necessities such as diapers, feminine hygiene products, and car seats. These pressures make strong, accessible maternal health and child care infrastructure more important than ever. I want to thank you for Pennsylvania's continued investments in maternal and child health. Medicaid eligibility for 12 months postpartum has been transformational. The support for home visiting and behavioral health services, WIC modernization, and community-based prevention efforts. These policies make immeasurable differences for the families in our region. I also respectfully ask for your support in preserving and strengthening Pennsylvania's reproductive health safety care net. MFHS is one of 4 Pennsylvania recipients of federal Title X family planning funds, which has provided essential reproductive health services since 1970. Title X supports cancer screenings, contraceptive care, STI testing and treatment, pregnancy support, menopause care, health education, and referrals for low-income, uninsured, and underinsured individuals. More than 130,000 Pennsylvanians receive care through Title X centers each year, and federal funding for this program is uncertain. We're working with the Shapiro administration and legislative partners to identify policy solutions and to pursue sustainable funding to protect access to care. And thank you again for the opportunity to address you today. MFHS is proud to be your partner in this effort, and we look forward to answering any questions.
Thank you, ladies, for being here today. We're blessed to have you in our community. Jill, you're like a wizard of all kinds of statistics, and the Institute is fabulous for research and science-based research, which is most important when we have. Eddie Day-Pertinsky is a big fan of pilot programs, so thank you for being here today. Dr. Maria, we are so lucky to have you with us in this community. Really, I am a huge fan of preventative care. The outcome is always better when we have preventative care, but the access to preventative care for lots of moms and babies here is challenging. Moms and babies were the reason, I will tell you, the reason our hospital is still open. We struggled greatly to make sure that there was a buyer. And believe me, when I say we, my colleagues up here, we went to many providers, hospital systems in Pennsylvania. Unfortunately, and Dr. Conaway will probably agree, NICUs, moms and babies, delivering babies don't necessarily make the hospital a ton of money. They drive healthcare, mothers, and tend to make those kind of decisions for their families. But unfortunately, that is the population that was at high risk for closure. And that would have been catastrophic because most importantly, the patient population you take care of. So having access to delivery to NICU at that time is critical. But talk a little bit about, the fourth trimester, they call it now, that post baby, go home, having 4 of them. I know that all hell tends to break loose without the village.
Yes.
I was really fortunate because I had a lot of support. You are the village for lots of moms that do not have that support, certainly the ones in rural areas. And that statistic you just spoke about, that's, I think, 62%, correct me if I'm wrong, that that the mothers that actually are saying, I need that mental health, that behavioral health, that challenge that they're facing, that fourth trimester. Because I think we do really well at addressing and talking about, and before I let you answer the question, we in the legislature in Pennsylvania are really blessed with a group of women that we get to work with, Representative Mays, Representative Curry, Representative Cephas, who have been laser focused, and I know you had the opportunity to meet them and speak with them, who have been laser focused on good outcomes of maternal care, and certainly those rural access. So talk a little bit about that, because that's your patient population that I think needs you the most. So thank you.
You're spot on about needing the community, and we find that so much more clients are isolated. They don't come from big families. They come from families that may be states apart, and they don't have that support, particularly when they come home from the hospital, maybe have another child, and faced with, what am I going to do? So we have a fourth trimester program that takes mom through at least 3 months and as long as she needs. And behavioral health services are provided regardless of an ability to pay. We're never going to be able to support social workers' salaries on billing alone. The reimbursements are low, if they come at all. And unfortunately, if we didn't have the support of our foundations, we couldn't hire social workers. So it's critically important. Postpartum anxiety and depression is real. And you need to have supports, and it may not just be those 2 or 3 days in the hospital, it may be 6 weeks down the road. Breastfeeding has its challenges, and you may need support not just in the hospital that day you're getting discharged, but several weeks down the road, and we're here for you, whether it's for breast pumps or for confidence building. Soon, we are going to be a milk depot in Scranton, where we will be a milk bank where you can donate milk, and it will be sent to the Mid-Atlantic Mother's Milk Bank and processed and distributed to the hospitals and NICUs. So really excited about that. Fourth trimester starts with us with a home-delivered basket, a box of food for mom, which may have things in it like a frozen soup or other frozen things that can be just thrown together quickly. We work with the Indigo Spoon Foundation on that, and they're funded by supplied by the Weinberg Food Bank. We also have a car seat program and safety items for moms because, have you tried to purchase a car seat lately? $245 for my grandson. And by the way, don't take it out of the car because you'll never get it back in. But we have a whole team of people who are so extraordinarily focused on the outcomes for that particular family. It actually becomes difficult for them when there is a fetal demise or a miscarriage. They really work very hard to make sure that the families have what they need, but that's a very heavy load. So fourth trimester is tremendously important, and that's not really something that's funded by any reimbursements. So we do that because it's the right thing to do, and it has better birth outcomes.
Thank you so much for your testimony today. I have a little bit of a unique perspective, probably amongst my colleagues. I may be the only one that was actually a WIC participant myself about 13 years ago. So when I unexpectedly became pregnant with my twin daughters, I was on Medicaid, and I was a high-risk pregnancy. I spent 4 days a week in Abington Clinic getting the care that I needed. I was fortunate enough that I had a hospital 15 minutes away that was able to provide the care, but I would sit for hours and hours in waiting rooms for my appointment time that was scheduled. I spent more time in Abington Hospital than I would ever care to do again, but I learned just how fortunate I was to be in a position that I could get Medicaid, I could go 15 minutes away, I could sit for hours but still get the care that I needed for myself and my children. I know that there are so many women in positions across the Commonwealth that they do not receive that type of care. And I know that going through the process, they immediately set me up on how to get involved in the WIC program and to be able to get to the food that I needed for my children and myself. And it was a lifeline in times when I was that mom that literally figured out how to super coupons so that I could put food on the table. I mean, the grocery store had to zero balance me out because they owed me money at checkout. There are things that as a mother, we have to do whatever we have to do for our children, but sometimes it's very isolating when you feel like you cannot give enough or you cannot do enough to support your children. So knowing that there are safety networks out there like yours that are stepping up to help the women and the families that need you the most, it is such an incredible thing that you guys do. So I don't have a question. I just want to say from the bottom of my heart, as someone who has received the services and truly benefited from them, thank you for the work that you do.
I appreciate those comments. What county were you in?
Murray County.
Yes, you're the WIC provider in Montgomery County. Right, everybody else does, yes.
Okay. All right, Missy, you turned it off now. Thank you, ladies, so much, and thank you for the work that you do. As my colleague, Rep. Serrato, said, it's definitely so valuable. I'm from Delaware County, and we have our fantastic Foundation for Delaware County that runs our WIC program and similar programs down there. So it is, absolutely essential. My question for you is, I guess it's two. So first, what could we do as legislators to better support the work that you do? How could we provide more opportunities besides funding? I know funding is always an issue for sure, and we definitely are working on that. And if that's the thing, then let us know that too. But what else could we do? Is there something legislatively, something in the advocacy world? What can we do? And I know Rep. Kosierowski mentioned our colleagues, Rep. Curry, Rep. Mays, and Rep. Cephas, who run the Black Maternal Health Program. I'm a member, or the caucus, I'm a member of that caucus, and have seen some of the transformational work that they have started to do and have been able to encourage across the Commonwealth. So we know it's definitely so needed, and programs like yours, like what else can we do to bolster the work that you're doing and help you expand so that you can reach more people? And also maybe you could just also tell me a little bit, how do you differ from going to a physician's office? So, I have two boys, granted they are old, it's been a long time since I had them. But, how do you guys differ from a physician office as opposed to when it comes to the care and what you offer?
I'll start there. So again, we are not in competition with physician groups, absolutely not. But we have the resources that they may not have. So if they have a mom who is in need of oral health care and can't get it, we have those services, and we do accept medical assistance. And also, for our clients, we pretty much have a very focused oral health care practice. It's just for the folks who are receiving WIC or prenatal through us. And so if an individual can't pay, that's okay too. We'll take care of that. But we provide all of the wraparound supports that the practices may think of an individual as non-compliant. They never come to their appointments. They're always late. They always want to bring the kids, and that's okay. That's our people. So for mom who can't go to the postpartum appointment because she can't bring the newborn, but she doesn't have anybody to babysit for her, that's okay. Somebody will hold that baby while you're getting your appointment. Transportation is a barrier. Sure, there's bus routes. Have you tried to take a stroller down a hill in Scranton in this weather to get a bus to go to your appointment? It's insane. And so we can use Uber Health to be able to pick up the mom with the car seat and get them to the appointment. And then while they're there, we can take care of everything in the one location. So someone will pop in to see how you're doing emotionally. Do you need to talk to the social worker? Do you want to talk to the social worker? Do you have maternity clothes? Are you okay with that? Do you have a winter coat that fits right now? How about boots? Are you okay? And so we provide all of those wraparound services that I am sure that every OBGYN would want to be able to provide, but they can't, especially with a 15-minute appointment. So sure, there are people who want to be in and out of their prenatal appointment, 15 minutes and done, but there are other folks who really need to sit with somebody for a half hour and talk about where they're at and what they're worried about and where they're feeling very vulnerable. So that's really the difference.
Thank you. Oh, wait, you didn't answer. What can we do to help you?
What can we do to help? Well, managed care organizations are the bane of our existence. We know they get a per member, per month fee, and I don't believe those resources are being passed along adequately to the providers. I know that there are MCOs that are receiving money for transportation for maternity care. We're never seeing it. We're raising those monies ourselves. And also, they deny claims, I think, just as part of a business practice. So we're waiting weeks and weeks and weeks, months and months and months. And so for an organization that operates on such a narrow margin, if we don't get the billing that we need, if we don't get the reimbursements, like in the fall when we were missing so many federal and state payments, we're out on a line of credit to be able to make payroll. And then, unfortunately, we're paying interest on the line of credit, so now we're further behind. The managed care organizations need to pay promptly, and this denying services just as a business model is absolutely ridiculous. Do you want to comment on
I think I'm just going to add that everything Maria just said about MCOs is really, really important. And I think to kind of zoom out and thinking about supporting, whether it's supporting existing policy or proposing your own policy that helps remove those social determinants of health-related barriers, because although they are not directly related to healthcare in and of itself, everything is very much interconnected, and access is a very big issue. My top three kind of soapboxes have to do with transportation, childcare, and housing. And not only do those things impact individuals who are seeking care, but it's really a matter of the workforce development end of things. There is such a tremendous workforce shortage, and the transportation, for example, particularly in rural areas, but even here where there are bus systems, they are not operating around the clock when hospital systems very much do need to operate. There's a tremendous childcare shortage that's keeping people at home and unable to enter the sector. And then housing, of course, that's a national issue, but it's exacerbated here in northeastern Pennsylvania. And when we need to attract a workforce from other areas, we have to make sure that we're making it as desirable a place to live and work as possible. So I think I would ask to kind of keep all of those other elements in mind as well.
Our clients are among the hardest working people I've ever encountered. When we opened our Circle of Care location in the flats down by the bowling alley above Voodoo, we had to adjust our WIC hours because moms needed to get there before work or come after work, and that we do that. But these are not folks who are just staying home. They are working a job, more than one job. Their families are very industrious, and we really are privileged to be able to provide that support.
Oh, now, okay. This is really interesting testimony, especially when you're combining the data with the real world, delivery of what this means. You mentioned WIC and nutrition and early childhood. Obviously, we know that's federal. So WIC is a federal funding that's out of the U.S. Department of Agriculture, as is SNAP program, which is funded with the Farm Bill, which is, I think, 5 or 6 years overdue to be updated in the federal government, which is a significant, really a decline in benefit that comes out of there, because even flat funding something when you have inflation on food costs have gone significantly higher than a continued flat funding. So you're getting less and less food and nutrition for kids, right? And WIC, and you're going down. And that's federal funding that kind of flows through the state. But I'm really curious because we tend to suggest that the cost is the gap between we used to get this and now we get this with nutrition, and the gap is, and the cost of it is, whatever, $1 million or something. But I think the real cost is health outcomes and the cost of healthcare. Like, one of the things you mentioned is interest carry costs. If I deny payment and I'm the managed care and I have millions and millions of dollars in my bank account that I'm earning interest on, that's your money. When they reimburse you, they don't give you the interest that they earned on it.
No, they don't. And actually, they will take money out of your account if they think they've made a mistake. They'll go back and get it. Now, then they may find it, and then they'll put it back. But that's really difficult. They do. They have a lot of power. It's true.
But I'm wondering if there's any data on cost of reducing nutrition in terms of the rate of care with these families that are with kids. How much does it end up costing after the fact?
Yeah, there are studies that come out every year from WIC. I don't have one at the top of my head now, but I'm sure that we can find something. But you're right about, these are upstream programs. And the Nurse Family Partnership is also well documented as an upstream program, that the more you invest in the child and keeping them on the right path, Nurse Family Partnership is an evidence-based program. And so there are studies that have shown that the more access children have to those first 2 years of good health and solid care, it removes those downstream costs decades to come. And I think that's probably something you're thinking about. So there are many surveys that we can look into that show where the upstream benefit is to the future.
Yeah, and I think it's really important because we're data-driven a lot of times.
Mhm.
The other side of the argument of how much will this cost? And the real question is, how much is it costing us?
Mhm. Yeah.
The more data you can supply us
Mhm.
and say,
Mhm.
oh no, it's not costing us this gap, this
Mhm.
$100,000. This is costing us millions and millions of dollars down here.
Yeah.
Because we failed to, right?
That, absolutely. It's a good point.
It helps us.
Well, when you think about it, the average WIC package is about $80 per participant. So if you have 50,000 participants times $80 a month, that's money that's going into every grocery store. So anytime that we're not being able to give out, to get clients connected with WIC because they're on a waiting list, that's money that's not going into your local grocery store. And that's very easy to calculate. We can come back with that.
Again, the vast majority of your funding comes from the USDA, and last year, the chaos in Washington, they did go after WIC.
They did.
And it was one of the few times our Congress stood up to the president.
That's right.
Any rumblings currently on funding? I know it's been flat funded, the
Well,
farm
so
bill's pending.
We have funding through September 30th, through the federal fiscal year. But what we need to do with WIC, and I know this is at the national level, we need to get WIC included with the national breakfast program, the school lunch breakfast program, so that it is always in there. WIC right now has to be renewed every year, and that's a problem.
As a side note, they're also attacking that food program for the kids in
Mhm.
school, so.
Right.
Thank you, Dr. Edwards and Jill, for coming out today. I just want to give a plug to Dr. Edwards' program because when I first got elected, I think I was down for the grand opening of
Yeah.
your Circle of
Yeah.
Care. And at the time, I had a 21-month-old and a 4-month-old. So we were going through, right, those same difficulties. And we were blessed to have the resources and the village around us to help out when we needed it. And just seeing what you did there really touched my heart. I had the privilege of being a suite mate with Representative Curry,
Curry,
and
yeah,
she
yeah.
would talk all the time about maternal health, Black maternal health, and I kept on saying, you have to come up, you have to come up, you have to come up. And a little over a year ago, she came up and she really was amazed with the program that you're offering and trying to make that a model across the state to provide that care. So thank you for what you do.
Thank you. We think that it can be replicated in other parts of the state because the model is going to look different in every county. What we have in Scranton, we have our WIC location, and WIC has to be engaged in any of these circles of care. And so reproductive health is also engaged, so because birth spacing, I mean, you've got to give your body a chance to heal. And all of the social supports, the behavioral health pieces, we even do cooking classes because I can't tell you how many families don't know what to do with real fruits and vegetables. And so we do provide recipes and cooking demos, whether it's online or in person, both are very popular. And so we could take all of these things that are needed in community and connect them virtually or physically, but I think we can do a better job of linking all of those resources with care coordinators, navigators.
Thank you.
Thank you very much to both of you. Thank you for what you both do for our village. We're all of us up here, and of course the surrounding area, are lucky to be in your company, and we appreciate both of your professional paths. And how you're serving this conversation and the populations you do. I think, we are data-driven and serious legislators and policymakers up here. And even, Representative Lisa Borowski asked for homework. So I hope that you are left with the impression of that we are taking this very seriously, and whatever isn't already enacted or part of a budget or having a bill number will be taken seriously from this opportunity to discuss policy. I think we have our work cut out for us. And Doctor, how, you never seem overwhelmed, but I can't imagine the demand at your doorstep. I guess the best way to ask the question is how much of it, if you could quantify the unmet need or demand out there in our community for your services, that you just, whether it be from a federal funding stream or just at a more micro local level, facility-wise, just don't have the capacity to serve or meet people where they're at.
Well, one of the things is that we don't have a sexual health education curriculum in Pennsylvania. And we have so many young people coming in, they know nothing. And it's so sad. I mean, I have 7 younger brothers and sisters. My parents figured they'd teach me and I'd take care of the rest of them.
Through the Catholic way, though.
Yeah, but that's not happening. Kids don't know. They're not getting it in school. They're not getting it at home. And unfortunately, so many young people don't even know they're in an unhealthy relationship because that's all they've ever lived with. And so we do a lot on empowerment and helping to make good relationship choices. And those are kind of the soft things. It's not really, fundable anywhere, but it's that connection, that one-on-one connection. It's finding a trusted adult.
I appreciate that perspective very much. Joe?
Just to add to that, too, we do know that aside from long-term care, maternal health and reproductive health care is the fastest growing subsector in healthcare. And it's not necessarily because people are having more babies, the birth rates aren't really rising, but it's because the access, the services that are there are shrinking. And so it's kind of having an inverse relationship with the demand. So the demand is really growing in spite of that.
Much appreciate that. Okay.
Thank you.
Thank you so much. All right, we'll move on to our third and final panel with Jennifer Huber at Geisinger Community Medical Center, GCMC, with PASNAP, as well as Sue Wiggins, Medical Laboratory Technologist with SEIU. Appreciate you both so much for making time to be here and for always standing up for the amazing workforce that you do.
Thank you.
Good morning, and thank you, the House Majority Policy Committee, for this opportunity to be here today. My name is Jen Huber. I'm a registered nurse at Geisinger Community Medical Center for the last 23 years. I'm here to share what the nursing workforce crisis looks like on the ground in northeastern Pennsylvania. Sorry, it's a little emotional. In our region, the biggest challenge isn't just recruiting new nurses, it's keeping experienced nurses at the bedside. We're losing nurses to burnout, unsafe staffing, and working conditions that made it hard to provide the level of care to our patients and what they deserve. When nurses leave, the workload on those who remain increases, which only accelerates the problem. At GCMC and the hospitals across the area, short staffing has become normalized. Nurses are often responsible for more patients than it is safe, which affects patient outcomes, drives morale, distress among staff. Nurses don't leave because they don't care. They leave because they care deeply and feel that they are being set up to fail. This isn't just a workforce issue, it is a patient care issue and regional access issue. When hospitals can't retain nurses, units close, services are reduced, and patients face longer wait times and have to travel for their care. We've tried internal fixes such as committees, incentive programs, temporary staffing, but without real accountability and enforceable standards, those efforts does not address the root cause. Nurses want to stay at the bedside, but they need working conditions to make that sustainable. I appreciate the chance to be here today, and I look forward to answering any questions and discussing solutions that will help stabilize and retain nursing workforce. Thank you.
Good morning, and thank you to our state representatives for providing me with the opportunity to speak today. My name's Sue Wiggins. I've been a medical laboratory technologist for over 40 years and work at Regional Hospital. I'm also a proud member leader of our union, SEIU Healthcare Pennsylvania. Our union represents 800 members, almost all of the healthcare workers at Regional, which includes the Moses Taylor campus. We have helped lead the tireless advocacy efforts over the past year alongside our elected officials and community members to save our hospital. We are hopeful and relieved to finally have a new chapter for our hospital and a resolution to keep our hospital open. Tenor has respected our union by agreeing to our request to maintain our contract, and they have positively expressed a willingness to work together. Having a strong union voice empowers us to advocate for safe, quality patient care and good jobs that recruit and retain staff. We are committed to partnering as a union with Tenor to ensure the success of our hospital. Regional and Moses Taylor Hospital are absolutely critical for the care and economy of our entire area. The population of Northeast PA is older, sicker, and needs more complex care than ever before. Regional has over 381,000 patient visits a year, including 36,000 ER visits. We also deliver 1,700 babies a year, 70% of the births in Lackawanna-County, and have the only level 3 intensive care unit for newborns in the area. Our hospital needs a lot of improvements that can be achieved in part through new management leadership who is willing to work with and listen to those of us on the front lines. Based on recent town halls and conversations our union leadership has had with Tenor's CEO, it seems like we have the opportunity to build that collaborative approach. We are setting up a meeting with our union and Tenor leadership soon to start talking about how we work together to address immediate challenges. And we have a lot of work to do after years of underinvestment by CHS. We need to invest in the physical plant. Our hospitals are old and crumbling. We need new equipment and supplies. It is imperative that we have an immediate infusion of investment in these areas. We also need to rebuild a stable workforce. We've held on this far out of dedication to our patients and community. We are starting from a strong foundation with our current union contract, and we're proud of what we have achieved despite the challenging environment with CHS. But we need to build on this foundation and sustain our new optimism by providing competitive compensation and benefits that will recruit and retain staff. As you know, there is a healthcare workforce shortage crisis throughout nursing, techs, and almost every job title, which was aggravated by the pandemic and is only getting worse. Healthcare work is very tough physically, mentally, and emotionally. In order to attract qualified staff, it takes incentives like good benefits, longevity pay, and keeping up with whatever hospital is offering the latest sign-on bonus. The cost of living has increased by 25% over the past 5 years. Groceries, housing, childcare, and utilities have all gone through the roof, and our wages have not kept up, so regional workers are falling further behind. As we all struggle with affordability, one of our biggest focuses in our union contract negotiations will be keeping our out-of-pocket healthcare costs frozen for the upcoming year. We believe that if we improve the experience for our patients and the environment they receive care in, we can attract more patients and physicians. That will not only help us maintain services, but regrow ones that we've lost, such as hematology oncology, pulmonology, neurology, and maternal fetal specialists. We know the demand for healthcare is there. We just need to inform and reassure everyone in our area that they should come to regional to receive these high-quality services. The bottom line is that all of these necessary improvements will take real hard dollar investments. It is imperative for our community that Tenor follow through on their commitments and use their resources to invest in patient care and frontline staff. And for the sake of our hospital and our community, we need the help of our elected leaders here to provide oversight and ensure this investment happens in a timely manner. State dollars that could be allocated now or earmarked through the new rural health funding would be especially helpful to start immediate investment. So we urge our elected leaders to support Tenor's ability to invest in our hospital and our workforce. Finally, there are challenging times ahead given the cuts to Medicaid and Affordable Care Act subsidies under the President and Rob Bresnahan's devastating one big bill. Our hospital relies on Medicaid for 21% of revenue, and we will face lower reimbursement rates from the federal government. More uninsured people will need uncompensated care, and sicker patients who have not received primary care will be flooding our emergency room. It is our mission and our duty to care for everyone, even as that federal funding is slashed. So state-level policy and funding will be even more critical to support safety net hospitals like ours and rural hospitals in Northeast Pennsylvania like Wayne Memorial, where workers are also represented by SEIU Healthcare Pennsylvania. At the state level, we have a choice of either raising revenue or making painful cuts to services and jobs which will severely damage the health of our communities. We have fought too hard to keep our hospitals open to go backward. Our healthcare system is facing a crisis in large part because Pennsylvania has one of the most unfair tax systems in the country, which is rigged to favor wealthy elite over working people. As a union, we are a part of a broad coalition to make sure the wealthiest corporations and the richest billionaires pay their fair share to support our hospitals and healthcare system. In closing, we look forward to working with Tenor and have high expectations that they will invest in our hospital. There's a lot to do, and as we move forward, we need both support from state leaders and as well as oversight to ensure funding is invested in bedside care and frontline staff. We need both immediate and long-term policies, especially given the federal health care cuts, so our communities receive the quality health care services they deserve. Thank you.
Thank you. Thanks to both of you. Yes, Doctor.
I said one thing.
Yes.
1 second.
Go ahead.
I just want to publicly thank, and I don't know if I'm doing it as the administration from CHS or the administration from Tenor, but I will tell you the hospital would not have survived the last year without the help of Tenor.
Yes.
And it's really important for that to be acknowledged. So often people talk about that we're natural enemies or competitors, but we would not have survived without the help that they've given us.
Thank you, Dr. Conboy. It's so true. Yes, thank you. And I think we all tried to say that in many ways, but you kind of said exactly what I was going to say to the ladies here. Both of you are such advocates for those brothers and sisters that you represent, but honestly, we did our part. The foundations did what they did. The negotiations with the governor's team did what they did, but it was all of you that were there at that hospital, and it's generational, as Dr. Conboy had said. Sue, your testimony could have summarized everybody. You hit what Dr. Maria said, Jill, Dr. Conboy, Jennifer. You know, all of the statements that you just said is exactly why we are where we are now. So I'm very grateful for both of you to be here today, because I know you have the patient safety, the patients at heart, and that's why you stayed working with us. But sometimes, Jennifer, when you talk about the nursing shortage, I think I should probably go back, but I would be a huge liability on the floor. So no, I should not go back. So thank you, because it changes so much. And the critical care patients that you take care of on the floor now are not the kind of patients that were on the floor 20 years ago. They're not. They're the ICU patients. Just the med surge patients are the ICU patients, because they are not being, they're sent home. Patients are sent home. They want to be, the cost of taking care of a patient. So what you do, and you kind of highlight it, how hard it is and how much everything emotionally, physically, we didn't talk about workplace violence, but it's those ratios. So you're being sent onto the floor to take care of patients that are sicker, more acute, and you have less staff. So I do appreciate both what you've done to help keep the doors open of our hospitals. But my question, I guess, is you've said there's programs that you've done, incentives. Forgive me, I don't remember the exact wordage that you used about the actual programs that the hospital tried to be part of. And the transparency, I'm hopeful that Trenner will continue to speak with the unions and continue to support contracts and certainly the healthcare. That's going to be a huge part that we have to talk about, the cost of healthcare for you. But talk about a little bit about those incentives, those programs, and what more you think, because you're there, you know what the challenges are. And that, we talk about House Bill, I think it's 106 or 306 or something, I forget the number, but it's that patient ratio safety. And I talk about it all the time. This is what we need, but how do we recruit the nurses to get there? How are we going to make that? And that's always the other side talks to me about, oh yeah, that's great, the ratio numbers, but who's going to come back and work in the hospital? But you said it. Well, they don't want to because the environment. So talk a little bit about that.
So the environment is a little rough. You may have your ratios, if we did have our ratios set in stone, but the patients are much sicker. There's nowhere for them to go. I might have a patient that needs to go to ICU, and he's ICU care, but there's no bed. So now for the next 12 and a half hours of my shift, if that happened in the beginning of my shift, I'm now taking care of an ICU level patient on a telemetry unit where I am 4 to 5 to 1. And, in ICU, they're either a 1-to-1 or they have 2 patients, 1 to 2. So it makes it difficult. We do have RIC nurses that come. They kind of help out. They're like ICU nurses that kind of float through the hospital. But when we're at capacity, there's lots of emergencies, lots of codes, lots of rapid responses that he has to go to, so you're left with it. It just makes it difficult to bring those nurses back. They don't want to work like that. They're tired. At the end of the shift, we're looking at each other and it's not great shift, guys. We did great. We survived. And that everyone is in survival mode right now. After 3 12s in a row, it was nothing for us to go out and get some dinner. And all I can think about is just going home and ending the day and just recuperating to go back to do it again. I don't want to give up on my patients. I love being a bedside nurse. I've been doing it for 23 years. I was a certified nurse's aide for 11 years before that. This is all I know. I don't want to sit behind a desk. I want to be at the bedside and I want to stay there. And if we're all leaving and all your seasoned nurses are leaving, who's going to teach the younger ones?
That's my next question, because I remember when I graduated, we had a very rigorous preceptor program. I had a preceptor for 3 months before I was let loose.
Right.
So now that does not happen because we don't have the preceptors there. So these nurses they're so desperate to get a new nurse on the floor that I feel like they're being trained up and they're stressed.
Yes.
And they're let with a patient assignment and it's really difficult. It's hard. So I give you a lot of credit because
It's
you probably
hard.
teach a lot of the younger nurses.
It is hard, and when they're coming out of school, $200,000 in debt plus, and the pay on top of all the responsibility and all the extra stuff you have to do, this department's, short. So now nursing's going to pick up. Oh, we don't have transport today. So you now have to do all of this. Plus that ICU patient that you're waiting for a bed on, you now have to transport to the cath lab, down to the discharge lounge, and by the way, your other patient's in the hallway waiting for you, your new one. So it's just overwhelming. Over the years, you've learned how to challenge some of that, us senior nurses. But the younger nurses, they just can't handle that because I had a slow, gradual up to it where they didn't. They're being thrown at it altogether. We're not keeping them, but we're also burning out our older nurses. And I can't lose my coworkers. I work on a unit that there's probably about 10 of us. We're the only unit in the whole hospital that has 20 plus years on our unit. So we flow very well only because of all the senior nurses, but they're getting tired. They come to me every day I don't know how much longer I could do this. I don't know how much longer.
Thank you.
I'll pass it to Kyle Donahue here quick, but my wife and I are trying to make it through The Pit, the new hospital series, and watching it before bedtime is not a really relaxing enterprise, but I'm just thinking you live it for real. So thank you for that.
Thank you both for being here and doing what you do. I just have a question for Sue, because I know over the last 2 years, we've had multiple town halls with SEIU and the workers at Regional and Mercy, and we've talked about morale, and, we've tried to make the main point that protecting the workforce and protecting the people that are actually keeping the hospital open through the turmoil of the last 2 years was a priority. So could you speak on just a little bit on, has the acquisition by Tenor improved morale a little bit, and what could still be done, I think, to build on, and improve that morale within the workforce?
Workers are certainly relieved, they're excited. We need, especially in the laboratory, our technology is so outdated. We're worried that if something's going to break, they don't have parts to fix it at this point. Radiology has the same issues. But generally, I think everyone is thrilled that they see that there's going to be dollars coming in, investments are going to be made. We're very thankful that Tenor, acquired us, and that we can, move forward with this new chapter.
Thank you.
Well, I'm going to start with Sue. Thank you, Sue, for, your testimony, and you just reconfirmed the optimism that Tenor brought in to the staff, and that's always good to hear. And when you testified about the contract being recognized, and I was going to say before the doctor cut in and actually solidified it, in his testimony, he talked about the working relationship. So we have a system here in Northeast Pennsylvania where you have administration and staff that understand the need to work together, and it's just kudos to both sides, and I'm going to use that word, both sides, right? Because sometimes there is that split. And Doctor, for you to have that courage to restate that, thank you for your commitment to the staff here in the area. Bridget had mentioned, and she said she thought 106, and she was right. State staffing is House Bill 106, and it's stuck in the Senate. But a bill we did talk about yet, my own experience, and not in the Scranton system, but the Wilkes-Barre system. My mother-in-law, future mother-in-law, recently went to an emergency room. Hours later, there was no bed, and we were out in the hall. And they finally gave her a bed in the hall. She was fine, and we were fine. In fact, my fiance was calm. I was surprised. But I saw two things firsthand. I saw the situation of the overcrowding and the lack of proper staffing, which led to this. A family was not so nice. And then I saw a sick person who's sick, who's hurting, yet angry. So it's on both sides of us. And one was in a emergency room, and one was out in the hall, so you could overhear we were right there. How many years, Jen, are you a nurse?
23.
23. With this staffing situation and the overcrowding, I've witnessed firsthand. So have you been personally affected by another House bill that we have passed, 926, that will help protect workplace violence in the hospital system, that passed this House of Representatives, and it's sitting in the Senate. And it's, some of the things in there are so easy just to have a workplace violence committee, and it's fought sometimes because we don't have that cooperation between administrations that we do here in the Northeast. Have you been a victim of it personally, or have you witnessed an uptick in workplace violence?
Yes, I've actually been threatened by patients and/or families over the years. Worse now, since the pandemic, I feel like people are more angrier now than ever. I have been told they were going to get me in the parking lot afterwards because things didn't go in their favor. They didn't want to get discharged, and it was my fault, and threatening they're going to hurt you. You know, it's, you know, just getting up in your face, mad because they don't like the visiting policy, so they curse at you, obscenities. Yes, I've been a victim of that. That's almost on a daily basis.
So obviously by the testimony, 926 would be a help and needed.
Yes.
House Bill 926, thank you.
I'll ask a quick, short question because I think, you know, both of your testimonies is great, and Sue, but we're obviously finite resources, right? So typically, you know, there's two ways you can distribute the resources. One is a little bit to everybody where everything is not done well, or are there like really acute areas of crisis where we should focus our attention on funding that you know, whether they have, you know, community health outcomes are greatest affected by that, or mortality in more high-risk areas, what they might be. But if you had your magic wand on what's the most acute areas that, because we have limited resources and we have to triage our budget, where does that go in your opinion? If you could direct us to your sort of hierarchy.
Definitely, you know, how much it's going to come, you know, from 10 or whatever the new monies that are coming in, but the nursing and physician, like the specialties that we lost, we need them to desperately come back. We don't have a pulmonologist to oversee the ICU patients. No fetal maternal specialist for the NICU. I mean, I think some of those things will take priority, and definitely nursing shortages. Our patients are in the ER for lengthy hours because several reasons. I see them. Sometimes I don't feel in ER nursing there's basically 1 to 5 patients, and sometimes there's only so many nurses, so there's not enough nurses sometimes in the ER, and then we're not enough nurses on the floors to once the patients get admitted, so they're waiting hours for the beds to open up the beds again for all the people that are in our waiting room, which is sometimes over 10, 15 people deep. So definitely, to me, staffing, and then technology is really needed to be upgraded.
I also think staffing as well. It would tremendously help out our ER. Those nurses down there, it is just undescribable down there. My heart bleeds for them, and they complain the least. It is, my heart goes out to them, but we really need to help with those nurse-to-patient ratios. Would help out our ER, but the bulk of the problem is trying to get people into the profession because they see what's going on. I know when I started 23 years ago, I was one of 8 graduates that started on my unit. That is unheard of now. We're lucky in May if we get 1 or 2 graduates. Sometimes we get none. Back in the day, we used to stagger your start dates because there was so many of them. It would be groups of 8 that started in June, and then in July, and then in August, and staggered them. You don't see that anymore. And then once we got them, keep them. but everybody doesn't want to be a bedside nurse because it's very high stress, and they can go back to school and get their NP and work in an office in a doctor setting where, it's more predictable on getting out on time. Your 12-and-a-half-hour shift turns into 13, 14-hour shifts. It's hard. No breaks, no lunches, because you want to make sure your patients are getting to their destinations, because that's what you're cutting. I haven't eaten in the cafeteria, and I don't even know. It's been a long, long time. I would rather stay on the floor knowing that I'm staying on the floor so I know I can get out at a decent hour and get my charting done. I just choose to do that. And I know my patients need me, and I wouldn't want to give my partner 8 to 10 patients. She has hers plus mine while I go to lunch. So I don't want to do that to them, so I just stay.
Did you go? Okay. Thank you. Thank you both so much, really, for all that you do for our patients, you and your colleagues. My son's girlfriend is a nurse. She works down at Penn. She's actually a University of Scranton graduate. They both are. So I remember when she graduated in 2020, she went to work in a hospital, and she thought she was going to a geriatric floor, and it was immediately turned into a COVID floor because that was, at that time what we were living in. And I remember she was thrust into a situation that as a new grad, I don't think she was fully prepared for. I know none of us really were fully prepared for what COVID brought us, but so to Rep. Kosierowski's point of, these new nurses are coming out and they're being put in situations that are probably not giving them the time to acclimate, to, better learn. I mean, I know they learn a lot in school. I know they do a lot of, practical work while they're in school. But once you get out there and it's like the real world, it's, I think, a totally different experience. So, I know that is a huge issue. I know that the student debt is a huge issue, and that, I think, is keeping people out of many of the healthcare professions. And we are, trying to work on that. It's, I will say, for me, it's very frustrating to sit up here and hear, some of the things brought up, like ratio concerns, workplace violence. We have legislation that is sitting, waiting for action on that. So what I would just ask, so it's really not a question, but it's really, it is so important to hear your voices. And I know that, your unions representing you are very vocal. We hear from them all the time. But I would also I would ask that the rank and file also, help us, raise their voices as well. Because I think a lot of times, sometimes lobbyists or people like that aren't as, they're like, oh, that's lobbyists and that's what they do, or but it's so important to hear from, those of you who are living and experiencing it every day. And we know the challenges that you face up here are challenges that we're facing in Delaware County, are challenges we're facing in rural communities, and even in some places in the city. And, healthcare is under fire in so many ways. I said, I feel like it's a game of whack-a-mole, like you try to fix one problem and then another one, pops up and you're like, oh my God, I didn't even know that was an issue. So, I would just ask that you continue to raise your voices. I know our nurses, when we were struggling with the potential closure of Crozier Hospital Health System, they were the nurses and our patient, support teams. They were some of the most vocal and the most active in trying to help save the hospital. So your voices are powerful, and I would just ask that you continue. I know it's hard. I know it's a lot, but continue to do that, and and know that all of us sitting up here are working hard. To support you and to see if we can move some legislation that will really provide some relief. So thank you for all you do, and I appreciate your testimony today. So thank you.
Thank you.
Darty, I had a question. Very good, Lisa.
All right. thank you so much for your testimony and for everyone for coming here and participating and helping us to do better and more informed work at the state level on behalf of the people in our communities, our villages, to get to better outcomes and stronger communities. So with that, this meeting of the House Policy Committee is adjourned.